Okay, so my case presentation is going to be a non-ketotic hyperglycemic hematuria, mimicking hemorrhagic stroke. So non-ketotic hyperglycemic hematuria is an uncommon condition of hyperglycemia associated with chorea or bolism. Neuroimaging findings include hyperdense unilateral or bilateral lesions of the basal ganglia on CT and hypertense signals in the putamen on MRI. Given its broad clinical presentation and non-specific imaging findings, misdiagnosis can very easily occur. Nonketotic hyperglycemic hematuria remains a diagnostic challenge, and a high index of suspicion can lead to decreased rates of misdiagnosis and inappropriate management. So for our case presentation, we have a 57-year-old male with a past medical history of type 2 diabetes who presented to the ED for altered mental status and seizure activity. On his admission, he was found to be afebrile. He was mildly hypertensive at 150/109 and tachycardic at 155 beats per minute. On examination, he was unresponsive and had posturing. Seizure-like activity was reported by EMS during transport. Lab work showed hemoglobin A1C greater than 14.5. He also had leukocytosis, an AKI, severe hypoglycemia of 755, and also high and metabolic acidosis with elevated lactic acid of 5.7. His beta hydroxybutyrate was found to be 3.8, osmolality elevated at 363, and his ABG showed 7.27, 48, 355, and 20. CT brain on admission showed a left basal ganglia intracranial hemorrhage. The patient was intubated for airway protection, loaded on Keppra, insulin drip, given Ativan, and admitted to ICU. Of note, this ABG was taken after being intubated. He had a repeat CT brain at 6 hours, showing no evidence of change in the left basal ganglia hyperdensity. The suspicion an MRI was obtained, and based on imaging criteria, the left basal ganglia hyperdensity was more likely representative of a non-ketotic hyperglycemic hematuria than hemorrhage. Blood glucose levels would manage, his hyperglycemic hyperosmolar state resolved, and he was extubated, and his neural function recovered. Of note, he had another admission a few weeks later with right-sided hemichorea and found again to be in hyperglycemic hyperosmolar state. For differential diagnosis of T1 signal hyperdensity, we have also NCCs, basal ganglia calcification, Tay-Sachs disease, tuberous sclerosis, and hyperintensive hemorrhages. So going into our discussion, hemichorea is an uncommon clinical presentation in the first place, which can very easily go unrecognized given its low prevalence in the clinical setting. This further challenges the recognition of non-ketotic hyperglycemic hemichorea as a manifestation of uncontrolled non-ketotic hyperglycemia. The patient originally presented with reported seizure-like activity and posturing, and these reports could have possibly and very easily been correlated for movements confused with seizure-like activity. Originally, the CT brain was read as a basal ganglia hemorrhage, so this elucidates how also imaging criteria can very easily be misdiagnosed, which likely contributes to the low prevalence of non-ketotic hyperglycemic hemichorea. In this case, our patient's poor blood glucose control made evident by profound hyperglycemia and also a high serum osmolality with no ketones in the setting, or barely any ketones in the setting of neurologic imaging findings and clinical presentation should have raised suspicion for non-ketotic hyperglycemic hematuria. Proposed pathophysiological mechanisms as to how this happens theorize that high blood sugar levels and impaired glucose metabolism promote a disruption in the blood-brain barrier, which allows leukocytes to cross and then causes localized injuries. Another proposed mechanism is altered perfusion in hyperosmotic hyperglycemic states, which lead to ischemic changes in GABAergic neurons, causing unopposed excitatory pathways. So far, non-ketotic hyperglycemic hematuria seems to have a good prognosis with tight blood glucose control. However, it is vastly unrecognized due to diagnostic challenges, and as we can see in this presentation, the variability in clinical presentation as well. So on the right, we can see the increased signal on T1 imaging in the basal ganglia location that our patient had. In conclusion, non-ketotic hyperglycemic hematuria is a rare neurologic complication of poorly controlled diabetes, which remains vastly unrecognized and hence underreported. We believe a high index of suspicion can decrease misdiagnosis and therefore avoid inappropriate and possibly harmful treatments that might arise from misdiagnosing this condition. Thank you.